So I want you to think of the human body as like a perfectly balanced city grid.
Right.
It's this highly regulated microscopic metropolis,
Yeah.
right? Every single cell, every nerve, every blood vessel has a very specific job just to keep the power running and the water flowing.
Yeah, exactly.
And usually, when you get a scrape or even like a broken bone, it's basically just a pothole on Main Street. It's annoying, sure, but the local repair crews handle it.
Yeah.
The rest of the city keeps humming along. But a severe burn, that is not a pothole.
Definitely not.
It's a massive system-wide power surge that threatens to melt the entire infrastructure right from the inside out.
And, the visible damage to the skin, no matter how awful it looks, is really just the epicenter of the event.
Right, the surface level.
Exactly. The true crisis that trauma teams are fighting against is the invisible systemic shockwave that just rips through the patient's entire cardiovascular and metabolic system.
Welcome to the Deep Dive. Today, our mission is to transform you into an armchair expert on the extreme physiological trauma of burns. We are diving into the high-stakes, ticking clock protocols that, medical professionals use to pull people back from the brink.
It's intense stuff.
It really is. And we're looking at an amazing set of sources today.
Yeah.
We have a deeply detailed medical presentation by Dr. and Birru, and we're looking at that alongside the official clinical practice guidelines developed by the Texas EMS Trauma and Acute Care Foundation.
And we should probably establish the stakes right up front, I think. We aren't talking about minor kitchen mishaps today.
Right, like grazing your hand on the oven.
Yeah, exactly. We are exploring the human body pushed to its absolute limits and, how medical science steps in when biology just starts to fail.
Okay, let's unpack this. Because to understand how trauma teams actually treat these injuries, we have to zoom way, way in. We need to look microscopically at what a burn actually does to your cells.
Right down to the building blocks?
Yeah. Dr. Birru's notes pinpoint the biological tipping point at exactly 111 degrees Fahrenheit. That's about 44 degrees Celsius. At that specific temperature, the basic building blocks of our biology just start to fail. The three-dimensional shape of cellular proteins actually begins to physically break down.
Yeah, the heat energy causes those tightly coiled proteins to literally unravel. They lose their structural integrity. I mean, if you've ever watched the clear part of an egg turn white and solid in a hot frying pan.
Oh yeah, the egg white.
Right, you've watched proteins denaturing. And once those proteins deform in the human body, the cell membranes, the protective walls holding the cell together, they completely rupture.
Which just sounds catastrophic on a microscopic level.
It is a microscopic catastrophe. Because under normal conditions, your cells carefully regulate electrolytes. But when those protective walls melt away, potassium rapidly leaks out of the cells and just floods the body.
Wait, and what happens to the water?
Well, water and sodium get violently sucked into the damaged cells, which causes them to swell up and literally burst.
Wow. Okay, so I saw a phrase in the clinical guidelines describing this next phase that really caught my eye. They call it third spacing.
Ah, yes.
Third spacing.
I mean, I get the concept of edema, where the tissue swells up, but what exactly are the first two spaces? Why is the body, flooding its own tissues?
Well, it helps to visualize the fluid compartments in the body. So the first space is inside your blood vessels, your veins and arteries. The second space is inside your actual cells.
Okay, so vessels and cells.
Right. And the third space is the interstitial void. It's the empty areas between the cells and the blood vessels.
Got it.
When the body realizes it's under attack from this massive cellular destruction, it triggers a severe inflammatory cascade. It dumps mediators like histamines and cytokines into the bloodstream.
And what do those do?
They cause the walls of the blood vessels to become incredibly porous. They essentially just open up, allowing vital fluid from the blood to leak out into that empty third space.
So, returning to our city grid analogy, it's like opening every single fire hydrant in a city all at once to put out a localized fire. That's actually a great way to look at it.
The water floods the streets,
Yeah.
but in doing so, the water pressure inside the actual pipes drops to, dangerous lethal levels everywhere else.
Exactly. And that drop in water pressure is what emergency doctors call severe hypovolemia, or, burn shock.
Burn shock, right.
Because so much fluid is leaking out of the blood vessels and pooling in the tissues, the actual volume of circulating blood just plummets.
Meaning the heart is pumping, but it's pumping empty.
Right. The heart is still pumping furiously, but there isn't enough fluid left in the pipes to deliver oxygen to vital organs like the kidneys, the liver, the stomach. Without rapid intervention, those organs literally suffocate and begin to shut down.
And while all this fluid is shifting and the organs are starving for oxygen, the body's alarm system is absolutely shrieking. The fight-or-flight response just kicks into high gear.
Oh, massively.
The brain triggers this massive dump of catecholamines and cortisol, these powerful stress hormones, and the presentation highlights something that completely blew my mind.
The duration of it, right.
Yes. This hypermetabolic state doesn't just last for a few days while the skin heals. It can inexplicably last for years.
Yeah, a severe burn puts the body into such a profound state of emergency that it entirely rewires its baseline metabolism.
That is just wild to me.
For years after the initial injury, a survivor might experience an abnormally fast resting heart rate, elevated core temperatures, and a continuously compromised immune system.
It's just constantly redlining.
Exactly. The body's desperate, prolonged attempt to heal actually exhausts its own reserves. In many ways, running that biological engine at the red line for years becomes almost as dangerous as the initial burn itself.
So since the true underlying threat is that microscopic cell wall collapsing, it makes perfect sense that fire isn't the only thing capable of tearing it down.
Not at all.
Let's look at the incredibly diverse culprits behind these injuries. Thermal burns are obviously the most common, right? Like 85 to 95% of burn cases in the U.S.
Yep, the classic dry heat from a fire or wet heat from scalding liquids.
Right. And tragically, scalds are the leading cause of burns for children under 5. But there are plenty of other forces that can trigger this exact same cellular destruction.
Friction is a surprisingly common one.
Like a carpet burn?
Or motorcycle accidents. If someone slides across the asphalt, it's a dual injury.
Yeah.
The mechanical force tears away the skin, causing an abrasion, but the intense friction generates enough physical heat to cause a legitimate thermal burn at the cellular level.
Oh, wow.
Then you have radiation burns, which can range from a severe, everyday UV sunburn to, deep tissue damage from prolonged medical radiotherapy.
And then we reach the opposite end of the thermometer, cold burns.
Right.
Here's where it gets really interesting to me, because we colloquially know that frostbite is terrible, but the medical guidelines actually classify it as a burn.
They do.
So is frostbite essentially like freezer burn on meat?
Right.
Like, does extreme cold shred the cell walls in the exact same way a hot stove would?
Well, the mechanism of destruction is different, but the catastrophic result for the cell is identical. Frostbite happens in this vicious progression.
Okay.
It starts as frostnip, bringing that familiar numbness and stinging pain. Then it progresses to superficial frostbite, where the skin turns pale and begins to blister hours after you try to warm it up.
Ouch.
But deep frostbite occurs when the freezing penetrates so far that the tissue actually dies. The skin turns white, then blue-gray, and finally black. All sensation is totally lost.
Because the nerves are dead.
Exactly. And what is happening on a microscopic level is that ice crystals are forming inside the tissue. Those crystals act like millions of microscopic daggers, literally physically shredding the cell membranes from the inside out.
Ugh, that is horrifying, which unleashes that exact same inflammatory cascade and fluid shift we see with heat.
Yep.
That brings us to chemical burns. And the Texas EMS protocols draw a very sharp, very terrifying distinction here between acids and alkalis.
They treat them completely differently.
Right. Why is spilling a strong alkali like a severe industrial detergent or drain cleaner considered so much worse than spilling a strong acid?
It comes down to two terrifying medical terms: coagulation necrosis versus liquefaction necrosis.
Okay, lay that on me.
When a strong acid hits the skin, it causes coagulation necrosis. The acid essentially cooks the proteins, much like that egg white we talked about earlier.
All right, it hardens?
Exactly. It creates a hardened barrier, a tough scab of dead tissue, which actually helps block the acid from penetrating deeper into the body.
Okay, so the body's reaction kind of shields itself.
Right. But alkalis cause liquefaction necrosis. They literally melt the fats and proteins, turning the tissue into a soupy liquid.
Oh my God.
Yeah. Because there is no hardened barrier, the chemical just keeps driving deeper and deeper, actively liquefying healthy tissue along the way.
Which explains why the EMS guidelines are so incredibly rigid about the very first step of treatment for a chemical burn. Like, standard burn care doesn't even start immediately.
No, it can't.
The protocols mandate that first responders must decontaminate the patient, flushing the area with water for a minimum of 20 minutes or until the burning process has completely stopped.
Right, because until you physically wash that chemical away, it is just going to keep eating through the patient.
Wow.
And that leads directly into the hidden, highly lethal mechanism of electrical burns, whether it's high voltage from a power line or, low voltage from a toddler biting an electrical cord.
Right.
The electricity itself burns the skin at the entrance and exit points. But the real danger is the invisible path the current takes as it travels through the inside of the body.
Right, because the current travels along the path of least resistance, which usually means it cooks the muscles and blood vessels from the inside.
Precisely. And when deep muscle tissue is damaged that severely, the dying muscle cells release a massive protein called myoglobin directly into the bloodstream.
Okay, and what does myoglobin do?
Well, myoglobin is meant to stay inside the muscle to store oxygen, and these molecules are huge. So as the circulatory system carries this blood to the kidneys to be filtered, those massive myoglobin proteins act like wet cement being poured down a sink drain.
Oh, wow. They clog the filter.
They physically clog the microscopic renal tubules. If the medical team doesn't recognize the electrical nature of the burn and intervene immediately, the patient will go into acute kidney failure, completely separate from the external burn damage.
Man. So we know the diverse mechanisms of trauma. We know how the cells break down, how the fluid violently leaks into the third space, and how the organs are threatened.
Right.
Now, I want you to imagine you are a patient being rushed through the ER doors. The golden window has started. How do trauma teams look at this absolute chaos and figure out how to stop the fluid shift before the organs fail?
Well, they rely on strict, universally applied trauma protocols just to cut through the chaos, specifically the Advanced Trauma Life Support, or ATLS pathway. And the very first step might actually surprise you, because it isn't looking at the burn at all. It's the ABCs. Airway, breathing, circulation.
Yeah, the guidelines emphasize this over and over. They aren't examining the skin on the patient's arms or chest first. They're looking inside the mouth.
Exactly.
They are actively hunting for soot in the mouth and nose or singed facial hair. Because if a patient breathed in superheated air from a fire, their airway is going to swell shut.
It's guaranteed.
The doctors have to preemptively intubate, sliding a breathing tube down the throat while they still physically can, even if the patient is currently sitting up and breathing just fine, right?
Because once that inflammatory cascade we discussed reaches the airway tissues, the swelling happens with terrifying speed. I mean, the airway can close entirely in a matter of minutes.
That is so fast.
It really is. And once the breathing tube is secure, the team has to aggressively manage the environment. First responders might have wrapped the patient in wet dressings to cool the burn in the field, but the ER team will strip those off immediately.
Then they crank the thermostat in the trauma bay up to like 82 to 90 degrees Fahrenheit. It has to be completely sweltering in that room.
Oh, absolutely.
And the reason why is because the skin is the human body's thermostat and insulation. When the skin is destroyed, the patient loses their ability to retain heat. A lethal drop in body temperature hypothermia suddenly becomes a massive immediate risk.
And hypothermia can actually deepen the burn injury by further restricting blood flow to the damaged areas.
Oh, it gets worse.
So while they are keeping the room sweltering, the doctors assess the actual wounds. They classify the depth. First degree is superficial, like your standard sunburn.
Right.
Second degree involves blisters and damages the deeper layers of skin. Third degree is a full thickness burn. The skin often looks white or leathery because the intense heat has permanently clotted or thrombosed the blood vessels inside the tissue.
Leathery, right.
And finally, fourth degree burns are so deep they destroy the fat layer and reach all the way down to the fascia, the muscle, and even the bone.
So once they know how deep the damage goes, they have to figure out exactly how much of the body is covered. They calculate the total body surface area, or TBSA.
Yes, TBSA is crucial.
I've always heard about the rule of nines on medical shows, but I never quite understood the math. And the guidelines also mention the Lund-Browder chart and something called the Palmar method. How do they actually measure all this?
Well, for adults, the rule of nines is a rapid assessment tool that divides the body's surface area into multiples of 9%.
Okay.
So the entire head is 9%, each full arm is 9%, the front of the torso is 18%, the back is 18%, and each leg is 18%.
Makes sense.
But for children, they must use the Lund-Browder chart.
Why is that?
Because pediatric body proportions are completely different. I mean, a baby's head makes up a much larger percentage of their total surface area than an adult's.
Oh, sure. That makes sense.
Yeah.
And what about the Palmar method?
For smaller, scattered burns across the body, doctors use the Palmar method. The surface area of the patient's hand, including the palm and the fingers, represents exactly 1% of their total body surface area.
Wait, literally the patient's hand?
Yeah. The doctor will literally visually measure the scattered burns using the size of the patient's hand to get an accurate percentage.
That is so practical.
Oh,
And
but
this percentage isn't just for medical charting, right? It is the literal mathematical variable they must plug into a formula to dictate the single most critical intervention of the next 24 hours.
exactly.
This is how they stop the city from running out of water. Fluid resuscitation.
The moment those microscopic cells burst and the fluid shifts out of the blood vessels, a biological clock just starts ticking. The medical team has to pump massive amounts of intravenous fluids back into the patient to keep the blood volume up, just so the heart has something to pump.
But they don't just use plain water or standard saline. They typically use lactated Ringer's solution.
Right.
Why lactated Ringer's specifically? Like, what makes it better than standard saline for a burn patient?
Well, standard saline is mostly just salt and water. Lactated Ringer's is engineered to closely mimic the body's actual blood plasma.
Oh, interesting.
It contains specific concentrations of sodium, chloride, potassium, and calcium. Crucially, it contains lactate, which the liver converts into bicarbonate.
And what does that do?
It helps buffer the blood's pH level, which often becomes dangerously acidic during severe burn shock.
Okay, so they use the total body surface area percentages to calculate exactly how many milliliters of this fluid to push into the veins. But they can't just check the blood pressure to see if it's working.
No, blood pressure isn't reliable here.
According to the guidelines, the ultimate speedometer for survival is urine output. If the kidneys are making urine, it proves the heart is successfully pushing blood all the way down to the renal arteries.
Yep. Urine output is the most reliable real-time indicator of organ perfusion. For an adult, the absolute strict goal is 30 cubic centimeters an hour.
Right.
But remember those electrical burns we discussed?
Oh, the ones with the myoglobin?
The ones that release massive myoglobin proteins that clog the kidneys like wet cement.
Yeah.
For electrical burns, the target urine output jumps drastically. The medical team aims for 75 to 100 cubic centimeters an hour.
Wow, that's a huge difference.
They have to violently flush the kidneys with massive amounts of fluid to force that myoglobin sludge out of the system before it destroys the renal tubules permanently.
Wait, hold on. You just said their blood volume is plummeting, the fluid is shifting, and the
Yeah.
body is clamping down on peripheral blood vessels to save the core organs.
Right.
Finding an 5E line in that chaos sounds nearly impossible, and these patients are in excruciating pain. Why wouldn't a doctor just jab a standard painkiller directly into a thigh or shoulder muscle and be done with it? Why do the guidelines absolutely forbid intramuscular injections?
It is a phenomenal question, and it goes right back to that invisible systemic shock wave. When you inject pain medication into a muscle during burn shock, the blood flow to that muscle is completely unpredictable due to the failing circulation.
So it might just not work.
The muscle tissue might not absorb the medication at all. The drug just sits there in the tissue. Imagine the doctor gives a second shot and then a third, assuming the medicine isn't working.
Okay.
Then suddenly, the intravenous fluid resuscitation starts to work, the blood volume recovers, and circulation returns to the muscle.
Oh, no.
Suddenly, all 3 doses of that powerful narcotic are absorbed into the bloodstream at the exact same time.
Which causes an overdose.
It can cause a massive lethal overdose. Every medication must go directly into a secure vein so the doctors have total control over the delivery.
The only exception the guidelines allow is a simple tetanus booster shot into the muscle. I mean, the body's transport system is completely broken.
Completely broken.
And this intense mathematical protocol has to be drastically altered depending on who is lying on the stretcher. The guidelines dedicate significant sections to vulnerable populations, specifically children and the elderly, because the math changes completely.
It really does. With pediatric patients, there is essentially zero margin for error. Children have a much higher surface-to-mass ratio, meaning their fluid losses are proportionately much greater than adults. They're at an extreme risk for lethal hypothermia.
And their metabolism's different too, right?
Yes. Furthermore, a child's liver hasn't fully developed its glycogen stores. Their tiny bodies burn through energy reserves so rapidly, just trying to stay warm and fight the trauma, that doctors must strictly monitor their blood glucose levels to prevent catastrophic drops in blood sugar.
And then there's the much darker side of the pediatric assessment. The trauma team isn't just looking at the math and the glucose. They are actively looking at the physical patterns of the burn on the child's skin.
Yeah, it is one of the most somber realities of emergency medicine.
Because they're looking for abuse.
Exactly. The team is trained to immediately look for signs of non-accidental trauma. Accidental burns, like a child reaching up and pulling a pot of hot water off a stove, usually have splatter marks and inconsistent, jagged edges because the child is moving, crying, and flailing away from the heat. But non-accidental burns, such as intentional scalds, often present with incredibly clean circumferential demarcation lines.
Ugh.
It looks like a perfect glove or the child forcibly held immobile in the burning liquid.
That is just absolutely heart-wrenching. You have to be the detective while actively trying to save a life.
It's incredibly heavy work.
On the completely opposite end of the spectrum, you have geriatric considerations. Think about how fragile an elderly person's system can be. Older patients have naturally thinner skin and usually poorer circulation and underlying heart conditions.
Treating an elderly burn patient is walking a terrifying medical tightrope. Because their skin is naturally thinner, what might be a moderate second-degree burn in a healthy 30-year-old is often a devastating third-degree burn in a senior.
So they need surgery faster.
They require surgical intervention much earlier. But the true danger lies in the fluid resuscitation.
Because of their hearts.
Exactly. You have to pump enough fluid into their veins to stop the burn shock. But if you push that fluid too fast, their older, weaker hearts simply cannot pump the volume efficiently. The fluid backs up and floods the lungs, causing a totally different kind of medical emergency.
It's this delicate, incredibly dangerous balance. And before we finish, we have to talk about one of the most drastic surgical interventions mentioned in these protocols. It's called an escharotomy.
Yes.
This procedure happens when a patient suffers what they call circumferential burns. That's burns that completely encircle a limb like an arm or a leg, or wrap entirely around the chest.
Right. And when third-degree burns completely wrap around a limb, the dead burned skin, known as the eschar, turns incredibly hard and leathery.
Like we mentioned earlier.
Yeah, it loses all of its natural elasticity. As the healthy tissue underneath begins to aggressively swell from the edema and the massive amounts of IV fluids being pumped in, that rigid ring of burned skin acts exactly like a tight leather belt.
Because it can't stretch.
It has absolutely no give. The swelling tissue crushes the delicate blood vessels against the unyielding leather of the burn, completely cutting off blood flow to the hand or the foot.
Or if the burn completely encircles the chest, the patient literally cannot breathe because their lungs cannot expand outward against that rigid cage of burned skin.
That is where the escharotomy comes in. Think of it like making a slit down the side of a sausage before you cook it so it doesn't explode.
Oh, wow. What a visual.
The surgeon takes a scalpel and slices deep, full-thickness incisions straight down through the leathery burned skin, cutting all the way into the subcutaneous fat layer.
Just to release the pressure.
Right. This physically breaks the tourniquet effect. It allows the underlying tissue to swell outward safely, instantly restoring blood flow to the dying limb, or, allowing the chest wall to physically rise and fall again.
It is brutal. Mechanical medicine utilized to solve a biological pressure cooker.
Very well said.
Well, we have covered an immense amount of ground today. We started by zooming all the way in to witness the microscopic destruction of cellular proteins at 111 degrees. We watched the cell membranes burst, triggering that massive, system-wide fluid shift into the third space.
And we explored how vastly different mechanisms, from scalding water to deep-freezing frostbite-shredding cells with ice crystals, to the liquefying damage of alkali chemicals, and the hidden renal dangers of myoglobin from electrical burns, all exploit those exact same biological vulnerabilities.
Right, and then we walked through the ER doors to witness the intense, ticking clock mathematics of survival. We looked at preemptive intubation, cranking the room temperature to 90 degrees to act as the body's missing thermostat, measuring scattered burns with the palm of a hand, and using urine output as the ultimate gauge.
To pump massive amounts of lactated ringers back into the body without causing a lethal overdose of pain medication or overloading a fragile heart.
The central takeaway, really, is that a severe burn is far more than a localized surface wound. It is a massive systemic cardiovascular and metabolic event that requires total physiological warfare from the medical team just to keep the patient alive.
Truly.
So to circle back to where we started, if a severe burn is a massive power surge that threatens to melt the entire city grid, the doctors are the emergency crews desperately rerouting the water and power to keep the infrastructure from collapsing. But here is a final thought for you to mull over as we end.
Yeah.
We learn that the body's reaction to this trauma That hypermetabolic fight-or-flight state fueled by stress hormones doesn't just end when the physical skin heals. It lasts for years.
Imagine what that actually means for a survivor's body.
Right.
Running an internal biological engine in the absolute red line zone day in and day out for years on end. How does the human body eventually rewire its energy consumption after being forced into survival mode for so long?
It's a huge question.
And what does living in that state of perpetual metabolic overdrive do to long-term cellular aging, long after the physical scars have closed and faded?
It really is a testament to just how deeply a burn changes us, inside and out. Thanks for joining us on this deep dive.